Good afternoon to all EUPSA members in Europe, and good morning for those in the West, and good evening for those in the East. On behalf of the EUPSA Educational Committee, I would like to thank, first of all, Ms. Gaia Tamaro, EUPSA Administrator, for the perfect organization of this webinar, and our two guest speakers, Professor Ramnath Subramaniam, Consultant Pediatric Urologist in Leeds, United Kingdom, and Professor in Pediatric Urology affiliated to the University of Leeds and Ghent, and Professor Mohan Gundeti, Professor of Pediatric Urology Pediatrics at University of Chicago, USA, who are two internationally recognized leaders in the field of pediatric robotics and laparoscopic surgery.
So I want to share my screen again, and Gaia can help me. Thank you. I want to share a few slides of, if you want to set up a program. Most centers have done their bit now. I think, still there are some centers who may be still in evolution of process. So first of all, I don't want to dwell into the football or soccer, but, you have to win. And if you want to win and you want your institution, does it want to win as well? Like you want to win, but your institution, your university, is it really invested in you and your program, and they want to be real a part of this? And if that is there, then things can move along very well. And if that intuition is not there, then things can be very difficult. So once say that they bought in and they say, all right, we are very interested, and please let me know your proposal or plan. And we are not MBA degrees, but we can do our business plan, and that based on a strength, weakness, opportunity, and threat. So how do you want to do? It may have been a committee at your hospital or university. It could be dean, CEO of the hospital, leadership, but you need to have a meeting of all the people who are involved in this and present them the business proposal in regards to how you're going to raise the capital budget. What is the cost? What's the productivity? Is it better? What is the literature available? And why you want to do it? So initial capital investment is really trouble, but you can have somebody buy in there. You can have some grants available from the various organizations in the world. They need to know that they have to invest in your training program initially, and there could be a loss of revenue, either operating room time, or you need more resources, or you need to go for training, and they need to know about it. And what's the benefit to the institution apart from the patient per self is there is a downstream revenue, and that downstream revenue, especially for those who are not funded by the government hospitals, and that could be very important. Now, in preparation for that, once you have all the buy-in people and everybody was willing, you need to start developing your team. And that team, as Ram again mentioned, is very important. It's just not you, but the lead surgeon, you under your care, you're going to build the OR team, you're going to build a marketing team, and you're going to build a team for maintenance and the business aspect. The OR space, you need a little bit more than compared to our old style because of the flow of equipments needed. Often you may have to bring the C-arm, and you may have ancillary equipments. So try to see if you have a biggest operating room in your own settings, and if somebody is doing it, then you may have to remodel the current space. As a lead surgeon, it is your role. You need to develop the team, and it's starting from anesthetists, who are very important aspect of whole this business aspect. And they may want to come and spend some time in an organization where robotic surgery is done very well. Your business manager may want to go and spend the time at the other institution to see how they keep the inventory of instruments, how they work with the supply chain, how they work with the maintenance of this thing. And initially, when you start, don't be on your own. If you have a surgeon who working with you as a co-surgeon, you guys both work together and make a team so that you get fatigued, your co-surgeon can come and help you, and you can both learn at the same time. And that's much better, effective way than just learning on your own. Once you get into this business, it's very troublesome to get the OR time, especially the block time. And you may want to divide according to everybody's volume that, this half day is for you, this day is for you. You need to keep the instrument supply very well because they have limited time. You can't keep on instrumenting the same thing. And suddenly you may find that, oh, instrument got expired. What should I do? So these are very small things. But I think, you need to keep a role on this and have everybody involved in this. Now, as a lead surgeon, you are very passionate and you do need to have the persistence and also, patience. That's a key for your success. And it goes with every profession, what we do, and the patience, and persistence is a unique thing. Once you have that, what is the training program? How do you want to get training? You may be expert, you may not need training, you can directly get onto it, but it may be helpful to streamline what you have, and you can start with just the dry labs. You can get some hands-on training in the wet labs. You attend some courses, you attend some workshops, and may spend some time watching somebody else doing it, how they are doing it. Then once you have your team, you start working on, don't work on your own initial couple cases, have somebody watch you, have somebody back up as you. So because essentially you don't want to put much of a carbon footprint on our patients, and our patients are pediatric patients, which are much more vulnerable than adult patients. So be careful about this and critically evaluate in between that, am I doing right? Am I doing best? What can I improve? And these are important questions to ask for yourself. There are multiple training programs available. As Ram mentioned, the European Academy course available. We have at institution a pediatric mini fellowship program, which has been very helpful for some of the surgeons around the world to develop their practice. There are multiple courses available, just like how you guys doing the courses. The one important aspect of the courses is the live surgery aspect. Though it's ethical, it's debatable, I think the live surgery has still some role in learning these surgeries. Now, as you go along every year, every 2 years, look back, keep all the records and make sure that you are improving well. Your outcomes and successes are better. Do critical analysis and try to work with multiple institutions to see if you can do multi-center output studies, which will help for other learners to understand how they can benefit from such studies. In regards to the progress of once you get this under the belt after pyeloplasty, you can move on to complex cases like lower urinary tract reconstructions and other complex reconstructions. But don't jump onto that immediately. Again, everybody's different. Some people may want to immediately jump onto complex procedure because they feel comfortable. That's absolutely fine. That's absolutely perfect. You are your own critical evaluator. Please remember that. This is a big slide. It's already published. You can go through this, how to develop the successful robotic program. And there are multiple intricacies involved in this, as we talked about just now. So with that, I want to say, if you want to get something done by the people, make it easy, remove the obstacles. And this is a quote by our Nobel Prize economic winner here at University of Chicago, Richard Thaler. And with that quote, I want to say thank you for all you. Thank you for the participant, and I'm open for questions.
Question will be in terms of the robot. Do you share with somebody, or it's just for the pediatric department, or do you share with other specialty and the cost and everything in your department? How do you, how is a robot basically, how is managed, the whole thing in terms of maintenance and who buys it?
So in Leeds, we have a children's hospital. We have our own robot. So it's basically managed by the pediatric surgeons and urologists, and we got a combined program going. So I mean, as Mohan said, it's all about business cases. You need to do at least about 125 to 150 procedures a year to break even, and the management to feel comfortable that they'll invest in a program for you. But if you're an adult, I mean, when we first started, we were an adult team, and like Mohan says, you need to then find out where is your block of theaters and timing to use the robot. But in children's hospital, luckily we have it for every 5 days, 6 days a week, the entire week, so we can manage it. But you need to be innovative, and just by doing pyeloplasties and nephrectomies, you're never going to put the benefit. And how I did it was by doing Mitrophanoffs, did tisurotomies in spina bifida patients. I did cost analysis, and I showed that by reducing the bed days in the United Kingdom, at least in our healthcare, each bed day is nearly 300 pounds. My patients were going on an average 2 to 3 days home compared to 5-7 days when they're open surgery with financial incision in spina bifida population, as you can imagine. And I showed that in the first 20 cases, we saved nearly 20,000 pounds. So you have to be smart, you have to be effective, you have to play it on their own game. Do you understand? You need to understand your healthcare, and that is a fundamental challenge. What Mohan has got challenges in the United States is very different from challenges that I have in UK, very different from what you have in Europe. But effectively, it's all being reactive, smart, and be one ahead of the game to convince the management that you're worth investing in it. And your patients are the best advocate. As much as you can get compliments, feedback, it helps a lot. So it depends, but generally it's just being determined and believing in the technique. For example, there are centers, I mean, we are the main center in the UK. In other centers, they're not even doing much because it's the vision, it's the leadership to take it to a different level, and you need to prove that to people. And then, so yeah, it's like that. Mohan and I have a similar personality. He's more soft-spoken than I am, but I'm generally, we are both determined people and you need that personality to drive things forward.
True. Mohan, what's the
Yes.
robot in your department? Is only yours, or you share with other specialty, or?
No, I don't have that liberty. I have to share. So what we have is we have a university's robotic program, and we have 4 robots in clinical operation. 1 is a single port and 3 are XI. And what we did is all our hospitals are connected to each other. So children's hospital, adult hospital, and they're like, probably 100 feet different each other. So we installed all the systems in the new operating rooms, which is our adult OR complex. So we have 4 robotic rooms there, and we allocated the time for each specialty every day. And that's how we've been very productive, because, I'm the only pediatric urologist and pediatric specialty using it, and it won't be that viable. So that, it's better that 4 of all using specialties is everyday use. And then we have 1 in the laboratory for training and, helping all the junior surgeons to learn on this. So that's how we operate the whole robotic program.
Very good. Very, very interesting. Now, I have another question on so always the approach is via transperitoneal approach. Am I right? All the procedure, most of pyeloplasty, nephrectomy, heminephrectomy. Am I correct in saying that with the robot, you always go transperitoneal, or you also have the retroperitoneal route as well? To both of you, please.
The vast majority of people do it transperitoneal. Even in laparoscopy or robotics, only because training is easy. For some people, retroperitoneal is very, very difficult. I did retroperitoneal laparoscopy, retroperitoneoscopic procedures before robot, and I also tried them when the robot came along. And although it is feasible, it's really, really challenging, and you cannot really train the people up that easily. So that's where I gave up, and I do transperitoneal for robotics. But I know that there are some people who are still trying to do retroperitoneoscopic surgery, particularly Thomas Blanc in France, in Paris, he's doing, because he was a disciple of Alain Gonemi. So they follow that trend of trying to do retroperitoneoscopic. But vast majority of people do it transperitoneal, I think. I know, Mohan, how you feel about it.
No, I agree with what you said. I think, mainly transperitoneal, and some are trying to approach retroperitoneal, as Ram mentioned. And adult urologists are also trying to get into retroperitoneum now to see if the renal surgeries will be helpful. So that will be something to look after in the future, and may have to compare transperitoneal and retroperitoneal, again, how we did it in the laparoscopic era. So that will be the future food for thought.
Thank you again, both of you. Now, I'm just going through the question. What is the lowest age, weight of the child that could tolerate robotic surgery? So again,
I don't think there's any low age weight where a child can tolerate. It is interesting story in during my experience. Initially, because I wanted to keep it safe, especially when I'm away from the department, I said we can only do under 1 year of age, 1 year or above. And 10 kilograms was the weight I let in. The lockdown, interestingly, made me use the air seal device now for patients because they wanted to use as a filter and prevent smoke coming out of the doing these minimally invasive procedures. As you can imagine, there's a lot of hoo-ha about it. And what I noticed with the air seal, that you can reduce the pressures to nearly 50%. So previously I was doing 10 and 12 millimeters of pressure. Now I do 5 and 6. And that has brought ability to bring even smaller child in. So now I am happy to relax it in the department. So although there is no set age limit, yes, you have to be careful, but it can be reduced down considerably provided you have the right equipment with you.
So I agree. I think the air seal is really important, and slowly you need to move on to, decrease the age and the weight of the surgery. It needs a lot of, some small adjustment, and slowly I moved down to, 5 kg, 6 kg, and the youngest one was like a 3.5 kg. And some of the intricacies involved we talked about, you may have to take into account. Now, rather than just the weight, what I noticed as I was doing more and more infants, the abdominal surface area, that determines a lot. And there are some different races, ethnicities, which have very small scaphoid abdomen with a small space. And even though they have weight like, 3.54 kg, the surface is very low, it gets very difficult. But there are some, ethnicities and different varieties, people who have, large abdominal surface area, and their weight may be just 3.5 kg, and it is much more easy to do that. I didn't come up with any objective assessment yet, but, again, we could go slowly lower down, but be careful that, be, careful and cognizant. Don't jump onto that, okay, all right, somebody did 4 kg, I will do 4 kg. No, go slowly and be safe.
okay, another question is about the transmesocolic approach for pyrolithotomy. If you have a big stone in the pelvis, you're going to do a robotic pyrolithotomy. Do you go transmesocolic or the standard way?
As a rule, vast majority of the left pyeloplasties, I do transmesocolic.
All right, okay.
Because it's much easier, you can see a pelvis sitting down there. On the right-hand side is different. You can do transmesocolic. So I don't think whether it's transmesocolic or retrocolic really matters. I think what matters is good exposure and be able to drive your camera through into some of the calyces if necessary to look for these stones and retrieve them. But yeah.
Mohan?
Yeah, I agree with the same. Nothing
Okay.
changed.
Now, another question is, how viable is doing a hidden incision robotic pyeloplasty in children where all ports can be placed below the belt line?
Don't know, never tried it in the robot, so it's not something that I can answer.
I think there's some colleagues have tried here in the United States. I don't have personal experience with either.
I think it's done. I think we've done no more questions. Can I remind everybody that the video of this webinar will be edited on the web, will be edited and will be available on the EUPSA website and the EUPSA YouTube channel. So, and loads of people tend to review the webinar afterwards in the YouTube channel. So just not for all the attendees here who came late, and for everybody else, it gets edited and it will be on the EUPSA YouTube channel. I would like to thank you again on the behalf of the EUPSA Education Committee, our two exceptional guest speakers. It's been a very, very interesting, fascinating talk, on the pyeloplasty, pyeloplasty, and setting up the system, the robotic training system into a hospital, especially for people who don't have the robot, and fascinating talk. Thank you again, Ram, and thank you, Mohan. And thanks Gaia for the perfect organization. And on behalf of EUPSA again, I wish you stay safe to everybody, and thanks again.
Thank you, everybody. Thanks a lot.
Thank you very much for being with us.
Thank you, Ram. Thanks,
Thank you.
Salva. Thanks, Gaia. Thank you, team.